Good morning, everyone. Today's topic is, from my side, is early and late complications following operative repair of Hirschsprung disease. And followingly, Dr. Siva will speak about the evaluation of a patient post-operatively. The topic is mainly divided into early and late complications. So among the early complications, as of for any common surgery, the complications like wound infection and bleeding will be there. Followingly, specific complications like anastomotic complication, that is leak, a pelvic abscess, a cuff abscess, dehiscence, retraction of the pull-through segment, and stomal complications are also there. So before coming to complications, let us discuss about some of the risk factors which are associated with these complications. And the risk factors mainly, for example, from this study, and the study is mainly was done in the case of transanal endorectal pull-through, and the risk factors which are associated with the short-term complications of the procedure. But these procedures, risk factors which I have highlighted is common to in all other procedures also, like Down syndrome in a Hirschsprung disease patient, preoperative enterocolitis, perioperative antibiotic use, duration of the operation, long segment disease, etc. will are common risk factors which further leads to complications in the patients. So wound infection is a very common complication, which ranges from 1.7 to 19.2% in incidence, and the main causes which are responsible, or the way through which it can be tackled, are adequate preoperative bowel preparation, preoperative antibiotic usage, and also the length of operation and preoperative nutrition. The dehiscence in following surgery in Hirschsprung disease, it usually occurs at the incidence of less than 3%, and it is associated with adequate hemostasis following the procedure, good nutrition, avoidance of ischemia, tension, and infection. While coming to specific complications like anastomotic complication, the leak in an following an Hirschsprung disease surgery is ranges from 1 to 10%, and it depends on the tension, the ischemia, and also the technical aspects of repair, and also poor nutritional status and residual ganglionosis and distal obstruction are also causes. Down syndrome in general is a general cause which leads to many short-term complications, and also post-operative rectal manipulation can also lead to leak, like post-operatively if in use of any suppositories or any use of other rectal manipulations can also lead to leak in case of Hirschsprung disease. So subclinically, if the leak is subclinical, the results it results in mostly strictures. So strictures, if we can say in other words, are in general are a sequelae of leak which have occurred in the post-operative period. And other, if it is clinically significant, it leads to localized abscesses, fistulas, peritoneal leakage, and also sepsis. So diagnosis is through water-soluble contrast enemas, and the management of leak is in generally required. We can do a percutaneous drainage, surgical exploration may be required, or otherwise it can also there will be also need for diverting proximal colostomy, or eventually an anastomotic revision may also be required. So this is an anastomotic leak following a SOS procedure. It is visible here, and further it has lead to a fistula after 2 months, that from a distal to proximal direction. And now next is pelvic abscess. In pelvic abscess, the incidence is less than 5%, And the risk factors are like same as mentioned for leak. For example, the technicality of the procedure, the tension and such. And the diagnosis of pelvic abscess is through CT scan. And why is it necessary? Is because it further lead to the extension of the infection and also the systemic sepsis. And necrosis of the pull-through segment can also occur. So the management is mainly through percutaneous drainage, or a stomal diversion may also be required. Cuff abscess is something which is formed between the muscularis layer and of the cuff, and also the pull-through segment. And it's mainly, as we know, following the Sauvé-Bolle operation. It further lead to ischemia, and the causes are mainly the ischemia of the child and also retained rectal mucosa in the cuff, and also bleeding. So it so it can be managed with antibiotic coverage, and also may percutaneous drainage may be required, or diversion should be performed. So the other short-term complication associated is the retraction of the pull-through segment. That is less than 10% of the cases we come across this, and this is early postoperative usually occurs in the early postoperative period. And the main diagnosis is through examination under anesthesia. And if it is a minimal retraction, it can be repaired through transanal repair. Otherwise, a proximal diverting colostomy and a delayed revision is after several months may be required. So the stomal complications are as common as in any surgery, like retraction, stenosis, parastomal hernia, skin breakdown, and prolapse. Coming to the late complication, which are the main issues we need to look upon on the long-term follow-up. And this is the reason why the patient of Hirschsprung disease should be kept in a closed loop in a long term. And the main complications, like the most serious one among them being the enterocolitis, followingly the most common being the constipation, and other complications like bowel obstruction, the most debilitating one, the incontinence issues, strictures, sphincter achalasia, voiding, and sexual dysfunction. So in this study, various complications associated with the types of procedures were being compared, and we can see Swenson's disease is associated with more episodes of enterocolitis and incontinence issues, and constipation was a common complication after Arabian puff repair. Coming to enterocolitis, can occur before and after surgery, and the pathophysiology and the theories behind enterocolitis to occur are as follows: like mechanical dilation and the fecal stasis which is occurring, and alteration of the mucinous component, and increase in prostaglandin activity. And further added with it will be the Clostridium difficile infection and rotavirus infection, and also the impaired immune defense mechanism. So this as a complex would lead to enterocolitis in children. So the risk factors, the high risk group, which is for enterocolitis, are the younger age, the Down syndrome, infants undergoing a primary endorectal pull-through are at higher risk compared to the stage procedure, and history of enterocolitis before surgery, and long-term long segment diseases. So it is said that the Swenson disease followed by Duhamel have a higher risk among and Sauvé's procedure have higher risk of enterocolitis. So the clinical presentation of enterocolitis is they present with abdominal distension, explosive diarrhea, foul smelling stool, vomiting, fever, lethargy, rectal bleeding, and shock. And a classical X-ray, which is suggestive of the bowel wall edema and bowel wall edema. Now, it is mainly associated, as I have said, with most associated primary endorectal pull-through than a two-stage procedure. So this is a Hirschsprung associated enterocolitis score for which a greater than 10 value would is suggestive of HAC. So in among the factors considered are diarrhea with explosive stool, diarrhea with foul smelling stool, diarrhea with bloody stool, and previous history of enterocolitis. And from physical examination, explosive discharge of gas and stool, that is blast sign on rectal examination, distended abdomen, decreased peripheral perfusion, lethargy, and fever. And among radiological features, multiple air fluid levels, dilated loops of bowel, sawtooth appearance with irregular mucosal thinning, cut-off sign in rectosigmoid with absence of distal air, and pneumatosis. And the laboratory findings like leukocytosis and shift to the left are considered in the scope. So for management, if a patient is have no signs of peritonitis or necrosis, we consider rectal tube decompression and thorough washes for the patient. Otherwise, we along with it, aggressive fluid resuscitation and bowel rest is required, and along with broad spectrum antibiotics. And in severe cases, that is worsening of peritonitis or clinical worsening, a resection with diversion may be also required. So in case of recurrent HAC, we should consider mechanical causes. And for mechanical causes, we should evaluate the patient with contrast enema, manometry, and rectal biopsy to rule out the mechanical causes. And further, it can be managed with botulinum toxin injection and internal sphincterectomy. Constipation being one of the most common complaint, incomplete resection may be considered one of the most common reason, like the discrepancy in frozen sections, and sphincter achalasia, stricture formation, fecaloma, neuropathic ganglionic bowel, and acquired proximal aganglionosis. And the theories began occur behind acquired proximal aganglionosis is that the vascular compromise which occur following the pull through with subsequent neuronal ischemia, or viral infections which lead to further neuronal loss or abnormally innervated proximal bowel. So initial management for this is with rectal washes, laxatives, and enemas. And if there is a failure to this bowel regime, we have to do a repeat biopsy and manometric analysis. For even though in general the constipation is said to improve with age and with a time period of the surgery, like for after a 5-year follow-up, the issues of constipation is commonly found out to be resolved in most of the patients. So bowel obstruction, in bowel obstruction, the causes of bowel obstruction are varying. One of the most common cause being adhesive bowel obstruction, and risk factors for this being prior operation, bleeding, leak, intraoperative contamination, dehiscence. And almost 20% of such patients are found to require surgical management. Internal hernia have incidence of less than 2%, and for this, we need to secure the mesentery of the pull-through segment. Twist of the pull-through segment is also a cause of early intestinal obstruction. Now, some specific causes like Duhamel spur, that is a return spur, that is anterior ganglionic bowel following the Duhamel spur, and which is filled with stool with obstruct the pull-through bowel. And the Sauvé cuff, that is a long when the Sauvé cuff is left in a long the length of the Sauvé cuff is much longer, it lead to narrowing, and which lead to further recurrent enterocolitis, constipation, or failure to thrive and functional obstruction. And for mostly this require physical examination, and it can be visualized in a contrast enema and reoperation with cuff resection may be required. Strictures strictures are also cause of obstruction, and it incidence is between 8 to 24%, and it's mostly occur following Sauvé and Svensson repair. The etiology is like the narrow muscular cuff, the technical complication, compromised blood supply, sequelae following an anastomotic leak, and failure to adhere to a dilation program. So it is diagnosed physically by a digital rectal examination and a proctoscopic examination. And we can consider stricturoplasty or redo pull-through procedure. Rectal dilation with Hagar dilators will also help after 3 to 4 weeks of the procedure. Sphincter achalasia is the failure of the internal sphincter to relax, and chronic constipation or it presents with chronic constipation or overflow incontinence. And the diagnosis is mainly through anal manometry, and in anal manometry we get a finding of persistent loss of normal relaxation of internal anal sphincter with distension. So the management is usually with repeated dilation, and if it is not responding, a lateral sphincterectomy or botulinum toxin injection can be done to the internal anal sphincter, and which effect is usually transient, that is less than 6 months. The botulinum toxin injection, for example, a study is conducted show that among 41 patients, the 25 that is 61% had a clinical improvement after botulinum toxin injection, and in 29 of the 41 patients, spontaneous defecation or treatment with laxatives was achieved. The defecation was achieved following that, and adverse effects were seen in 12 of the 41 patients, and this included anal pain, temporary loss of stools, and dermatitis. Continence issue is seen in 7% of the patient, and it is a factor which have a greatest negative impact on quality of life of the child. So the causes can be soiling following the surgery. It can be due to abnormal sensation, that is loss of sensation, and that is inability to feel the rectal distension, and loss of transitional epithelium following the surgery can be a cause of this loss of sensation, and abnormal sphincter function. Pseudo incontinence is associated with severe constipation, which further lead to fecaloma formation, and there will be loose stools which are occurring which are passed through the side of the fecaloma, and which results in soiling. And there is also it's also associated with hyperperistalsis of the pull-through segment. So it's usually worked up with barium enema, manometry, rectal biopsy, and MRI of the pelvis. Bowel control improves significantly with age and as a period from the procedure proceeds. Now, management is first line management in general. If we suspect the loose stools or the poor hyperperistalsis as the cause, we should start with dietary modification and bulking agents. And if constipation is a cause, laxative should be added. So the perianal excoriation are very common. It is very common after primary repair and stomach closure. It usually resolves between 2 to 3 months, and so therefore better is to start on with barrier creams from the postoperative day 1 itself. And coordinated care with a stomal therapist will help in further management. Voiding and sexual dysfunction are also one of the late complications which are associated, and for this a long-term follow-up of the patient is required. And the postoperative enuresis is as common as 9.5%, and it is most commonly seen with Sauvé's and Duhamel procedure and Svensson's, where a pelvic dissection is there, and it is assessed with the ultrasound for voiding MCU and urodynamic studies. Sexual dysfunction is also requires extensive long-term follow-up. 9% it's as common as 9% in Duhamel operation and 10% in Swenson's operation. The symptoms are like in female patients, it's associated with dyspareunia and primary infertility. And in male patients, it's poor erection, low sperm counts, or psychosexual problems. The summary is that there are wide spectrum of complications. The most serious late complication being the enterocolitis, and the complication which has the greatest negative impact on life is incontinence. So this patients should be kept in a long-term follow-up and in a closed loop for detecting these symptoms and getting it managed. Thank you.
The reference of all this data,
article.
For example, you are saying that on a female continence is more than powers compared with then you are saying that enterocolitis is 3 times more than compared with powers. What is the reference? 35% enterocolitis incidence compared to some 12% in the blessing solid.
Textbook.
What we learned is different from others.
Now I've reviewed the literature, sir. There are changes. I'll include in my presentation the updated literature on the incidence and complication and outcomes. I have the talk on post-operative assessment of the child and the outcomes as per current literature.
You don't go outside the rectum and do the dissection. So basically, you don't enter in the place where there are
Yes.
now. But then the presentation is saying
Yes, sir. I agree. Those were the percentages of previous data, sir. But now current data, as I'm updated in my presentation, I'll talk about it.
You don't think that this will get so they will be on that and they will change that.
In my half of the presentation, I would like to describe how to evaluate and manage a child who's not doing well after the surgery for Hirschsprung. Then we'll discuss briefly the outcomes and look at what the current literature tells us. And in the end, I'll summarize and conclude. So the best opportunity to actually critically evaluate all the results of surgery is the late follow-up period. And most reviews, however, have rather short follow-up periods. And the common problems that they describe are constipation, incontinence, and enterocolitis. The rare ones, however, can be fistulae, obstruction, and impotence. And early evaluation of this child who's not doing well is very crucial to improve these outcomes. So child who's not doing well, what is a child who's not doing well? One, who's having a soiling and fecal incontinence, or those who has persistent obstructive symptoms. And third group is a one with recurrent episodes of enterocolitis. So this has been very well described by the article on in the seminars in pediatric surgery, and most of the presentation on this part is based on this article. So what to do with a child with soiling and fecal incontinence? So basically, the Rome 4 definition of incontinence is that uncontrolled passage of solid or liquid stools at least twice a month is called incontinence. And this occurs in at least 40% of patients after pull-through. And like we've seen, causes of incontinence after Hirschsprung can be either grouped into ones that are due to abnormal sensation, one due to inadequate sphincter control, and one that is occurring with an intact continence mechanism. So with an abdominal sensation, that the child usually has inability to sense the distension of the neorectum, and there is the other cause could be a loss of transitional epithelium or the dentate line, which is leading to this. Then the inadequate sphincter control can happen if there is overstretching during the pull-through or any previous myomectomies and sphincterotomies that were older procedures that were done. But nowadays, those are not done. Then soiling with an intact continence mechanism can happen when there's fecal impaction or hypomotility. So if both sensation and sphincter mechanisms are intact, this is a child that has potential for normal bowel control in the future. If there is soiling, one should think about soiling in two ways. It could happen either because of overflow incontinence, which is happening because of a severe constipation or overflow of a liquid stool, or because of colonic hypermotility that is happening due to loss of rectum. Liquid stools usually are seen when there is more of a proximal segment of colon that is pulled through or the ileum that is pulled through. Colonic hypermotility, basically one will suspect when there is absence of colonic distension on a rectal edema, and this is confirmed by a Sitzmacher transit study or a colonic manometry, which are of these two, the colonic manometry is the one that is recently more practiced now. Now, how do we manage a child? So one should take detailed history and physical examination, preferably under general anesthesia. And this examination here, one should look for integrity of the dentate line. In this picture, we see that the pull-through was started from way to below, and there is loss of dentate line on follow-up in this patient who presented with incontinence. Additional investigations are done usually at the period of toilet training, like contrast enema, manometry, and motility assessment, which we'll discuss the algorithm in the further slides. So a child with weak sphincter weakness and poor sensation, now what to do? So most children here are can be managed with a constipating diet with stimulant laxatives and rectal or antegrade enemas. So here, lactulose and PEG, which are actually stool softeners, usually make incontinence problem worse. Biofeedback therapy and pelvic floor physiotherapy can be done in a patient that has, we're suspecting pelvic muscle floor weakness. And sphincter reconstruction procedure is one of the latest advances where it is recently proposed by certain centers that this helps in improving incontinence. But the results are not replicated in other centers. Then a child with severe constipation and an intact sphincter mechanism. Here, laxative therapy works best. Stool softeners, stimulative laxatives, enemas, all of these help. And a child with stool withholding behavior usually is a psychological issue, which we'll address in the next slides. This worsens if enemas are given in such children. Hyperperistalsis of colon, here again, constipating diet, fibers, all of these help. But additionally, loperamide is also beneficial because it decreases the motility of the colon. So we've dealt with that. Now we move to obstructive symptoms. So obstructive symptoms in a case of Hirschsprung are usually abdominal distension, bloating, borborygmy, vomiting, severe constipation, or difficulty to passage stools without the assistance of any rectal stimulation or irrigation. These causes are divided usually into 4 groups: the anatomical, pathological, functional, and stool holding behavior. Anatomical group could be due to either a stricture, a twist, a Duhamel spur, or a suave cuff like Joyel described. Pathological causes could be because of a pull-through of a aganglionic bowel, but that is less common. The most common cause would be a transition zone pull-through. And acquired aganglionosis or hypoganglionosis due to ganglion cell loss. Functional causes would be internal sphincter achondroplasias or motility disorders of the proximal bowel. Now, when we look at anatomical causes in the postoperative patient on follow-up, we should look for stricture. That this stricture can be diagnosed with the help of a clinical exam and a contrast study. And for management of stricture, usually repeated dilatations will help for most strictures. But if there are strictures not responding, that strictures too severe enough to cause almost complete narrowing of the rectum, even a redo pull-through might be required. For a twist, like seen in this contrast enema, if you're suspecting a twist, then this is almost a devastating complication, and this requires a surgery. Here in this surgery, we can, in this intraoperative photograph, you can see the more than 360-degree twist of the pull-through segment was there, causing the obstruction. Then a Duhamel spur usually leads to a blind pouch, and this can be diagnosed on examination under anesthesia. And this would entail a spur resection if it is reachable from within, from below, or even an excision of pouch by a laparotomy is required in severe cases and with a large dilated pouch. So I have a cuff, here a resection of cuff can be done. This image here with examination on anesthesia, one can see that this malleable retractor is placed in the ganglionic bowel, and here anteriorly there is a ganglionic bowel, and in between there is a spur which was excised in this procedure. Here the suave cuff, retained cuff, basically here there was an abscess with which was diagnosed by the increase in the presacral space with contrast leakage there. And this retained suave cuff was actually excised in the subsequent procedure. This is the cuff, the light pink thing that we are seeing here is the cuff that was retained, and this was posteriorly incised and excised. Then coming to the pathological causes. So if after the clinical examination and a contrast study, we rule out anatomical causes. But now we are moving on to pathological ones. So the step now will be a rectal biopsy. So to this rectal biopsy, now where do we perform it? So it is usually performed above the anastomosis. And if a Duhamel procedure is done, the biopsy is supposed to be done more posteriorly. And this can happen either if a transition zone is pulled through or a ganglion zone segment is pulled through. And characteristics of this repeat biopsy that we usually take are myenteric hypoganglionosis, hypertrophic nerves in the submucosa, or a subcircumferential aganglionosis. Hypertrophic nerves in the submucosa are usually defined by presence of more than 2 submucosal nerves with diameters more than 40 microns in a single hypophyte. One should remember that a rare cause of loss of aganglionotic cells is also possible that the child could have an acquired aganglionosis because of ischemia. Then this is a slide where here we can see the hypertrophic nerves in this picture that were taken from a patient, a post-operative patient of Hirschsprung, showing transition zone pulled. Now coming to functional causes. Functional causes, usually by now we've ruled out anatomical and pathological causes, and still the patient has constipation. So we look at manometry for help, and with the absence of rare, basically it helps us diagnose the internal sphincter achalasia, wherein the internal sphincter fails to relax based on even on rectal distension. And these children, usually this problem is settled by the age of 5 years, and manometry basically helps us to assess the basal sphincter tone, baseline sphincter tone, and also look for pelvic floor dyssynergia. And management is most commonly practiced these days is botulinum toxin, or even nowadays biofeedback therapy is also helpful. Botulinum toxin, the disadvantage is that repeated injections are usually required because of the less duration of effect, that is around 6 months. But useful adjuncts like calcium channel blockers and nitroglycerin creams have been seen to be helpful to prolong that effect. Coming to the other cause is abnormal proximal bowel motility. So if the problem of constipation does not resolve with botulinum toxin, one can suspect an associated motility disorder in the proximal colon. And colonic manometry is the most accurate study to diagnose this. However, older studies have described using of SITS marker or a radionuclide contrast, colonic contrast study to look at this. And this is done only after all the anatomical and pathological causes have been ruled out. Because if these are present and one performs the study, there'll be falsely positive study and lead to incorrect diagnosis. And usually these are rare cases, and it is described in literature that segmental resection of that dysfunctional colon was done to treat the constipation. Coming to stool withholding behavior. So many children with Hirschsprung eventually develop a functional megacolon due to stool withholding. So we know that absence of rare is present in a Hirschsprung child. And this usually, the proposed theory here is that it causes additive external sphincter pressure and it leads to painful evacuation of hard stool. And this results in a vicious cycle because a painful evacuation leads to more withholding and then more dilatation and then more constipation. Bowel management in these cases usually similar to that of functional constipation. Then we move on to children with recurrent enterocolitis. So, like we've described in the previous presentation, the clinical criteria for enterocolitis are broadly described as child with fever, abdominal distension, or diarrhea. And this usually is seen in children with obstructive symptoms. The most common current theory for enterocolitis is that obstruction is the one that is causing enterocolitis. Obstruction leading to stasis and then causing bacterial overload, then translocation, sepsis, and HAC. So HAC now is graded into three grades we'll describe in the next slide. One could suspect important factors of HAC like disturbances in the intestinal microbiome, the mucosal barrier, the altered mucosal-based immune response, and the bacterial translocation. X-ray is very helpful in diagnosing HAC, and here we see a abnormally dilated bowel with intestinal cutoff sign, which is characteristic of HAC. So the three grades of HAC described are grade 1, which is a possible HAC, 2 is a definitive, and 3 is a severe HAC. Clinically, the patient has anorexia, diarrhea, and a mild abdominal distension in the lower grade. And usually the radiographic picture is that of just mild ileus. And in a definitive HAC, one patient might have a past history of a previous episode of HAC, or the classic features that we see. The explosive diarrhea, features of fever, tachycardia, abdominal distension, tenderness, and an explosive gas or stool on digital examination. In these children, radiographic classic findings are seen where ileal gas pattern, air fluid levels, a dilated loop of bowel, and a cutoff of at the rectosigmoid. Coming to severe HAC, here the children are obstipated. They don't have explosive diarrhea. They are obstipated, obtunded, and these children present with shock. And on X-ray, usually we see a pneumatosis or even pneumoperitoneum in such cases when bowel is perforated. So how do we manage these three groups? So first patient can be disposed usually on OPD basis. A grade 2 child is usually managed either as an outpatient or inpatient depending on the clinical condition of the child. A third group child is usually managed as an inpatient and sometimes even might require ICU admission. So coming to the antibiotics, Metrogyl orally is sufficient usually to manage a grade 1 HAC, and one may consider rectal irrigations also. But for grade 2, oral metronidazole is to be given, or even IV can be given, but one should consider broad spectrum coverage too. Here, this article here on the guidelines that given for the HAC described that and broad spectrum antibiotics usually are ampicillin, gentamicin, or piptaz. In our practice, we usually give cefotaxime or ceftriaxone. Irrigations are a must in this grade 2 when compared to grade 1. Then a grade 3 child usually requires IV antibiotics, both broad spectrum and metronidazole. Rectal irrigations are to be done, and one should keep a close watch for pneumoperitoneum because that might require urgent surgical exploration. Sometimes, if the conservative management with IV antibiotics fails, then proximal diversion is also supposed to be done. Now we look at outcomes on the long-term studies and follow-ups in the existing literature on the outcomes. So incontinence usually has the greatest impact on the overall quality of life, and the accurate assessment usually is difficult. And earlier series up to early 2000s have all been based on retrospective reviews, and these have lacked careful stool assessment. And some series even failed to differentiate between small amount of soiling and significant incontinence. And the total incidence described in literature is now ranging between 3% to 8% only. And older series have the higher percentage of soiling. The overall trend, however, is increased improvement over time. And this is Orvar Svensson's own paper with a 25-year-old follow-up of his patients. And he has seen that in 64 patients that he followed over 25 years, only temporary late soiling was seen in 13%. And this is in these 13% patients, only 3.2% patients had permanent soiling. That was up to they were followed up to 5 years. But then if these patients were followed up to more than 11 years, none of them had soiling. So by adolescence, usually soiling also is settled and incontinence also is improved. Coming to stool frequency, usually this parameter is rarely reported in the larger studies of Hirschsprung. And I found 3 studies which described stooling frequency. One was by Liam et al., where they said that normal frequency was achieved in 94% of the patients who underwent Swensson's pull-through. And Erdek and Wilt et al. Described that over 5 out of 29 patients of their patients with endorectal pull-through had more than 3 bowel movements per day, and this also declined with time. A good paper by Teitelbaum et al. Described how over time his patients have showed improved stool frequency. So the frequency of stooling from immediate post-operative period to over the next 1 year improved from 5 to 8 to approximately 2, just 2 per day. In this paper, he has done a regression analysis also and showed how the stooling frequency has improved from time. First plot is of first 200 days of pull-through, and the next plot is up to 3 years of pull-through. Now, constipation. This is a frequent complaint of patient after pull-through, and mostly patients usually continue to, probably because they have a prolonged colonic transit time. An evaluation, like we've discussed, requires history, examination, and a subsequent workup. And many times, this constipation is short duration, it improves with time, and like we see in our patients also. And examination, one should definitely rule out a stricture and a spur if Duhamel is performed. In absence of any mechanical obstruction, like we described, complete workup is required. And when we see a study by Moore et al., which is a long-term clinical study of patients with obstructive symptoms, here, 1 out of 178 children, only 16% had obstructive symptoms at 4 or more years of age. And rectal biopsy, when were done in these 16 children, 13 of them had abdominal findings. So rectal biopsy is actually very helpful in a patient of follow-up with constipation. Here, 4 of them had a retained atrial segment and 9 of them had evidence of IND. So in these patients, manometric workup in their study from Cape Town, Africa, by the way, and there in their paper, they concluded that manometry was not that helpful and it was not predictor of any poor outcome. So in their group of patients, it did not help in overall assessment of the patient. Constipation rates usually are 6 to 11%. And overall, when we see broadly in all studies, Swenson's procedure has the highest incidence. And Soave in his own series showed that 14% of patients after Swenson's are constipated versus 6% of patients with Duhamel. In his series, he describes that almost none of his patients are constipated. Puri and Nixon et al. Have described, however, on the other hand, that 35% of patients with Swenson are constipated, and this is the probable possible reference for the previous presentation for constipation. This is an older study. And these studies usually don't describe severe constipation requiring a surgical intervention and some constipation needing medical intervention. The later studies, there are only two studies till now that describe such groups. And we see that only 25 to 30% of patients that present with constipation require a surgical intervention. And like we see, like total here, what happened was in these two studies, around 26 and 27 patients required just medication to improve their stool. And of these, only 8 and 7% of patients required surgical intervention.
How is this possible? For the technically or politically?
So Swenson, usually we do not, we are not seeing constipation also, sir. Like the described literature is just around 6 to 11%. But it usually will improve with time, like I described in the previous slide also. For 5 years, mostly people are relieved.
Technically, how is this possible? Logically. How many cases
So I have to get back and look. Dekha tha, but I don't remember the exact number now. Yes, that is an older study, sir. Both
technically, what I'm trying to ask is
more. It usually is constipation usually seen in either Duhamel or Soave, like Soave because of a cuff or Duhamel because of a ganglion pouch. Yes.
Why there has been highest?
Yes.
If you say incontinence is the highest in Swenson, I can apparently that's Swenson before every 9 and
but that is what literature is saying.
What the problem is that we are going all around it and we expect that we will be injuring the nerves. Now, these nerves may cause constipation, may cause incontinence, both of these things. So it is not necessary that with Swenson's only the incontinence will happen. This is one thing, and probably the rationale why the constipation is being seen more frequently. Now, regarding the Duhamel and the Soave, the specific complication if it occurs that leads to constipation. Suppose a retained disc which is large enough to cause the enlargement of the atrial segment of the bowel, that will lead to severe constipation and all. So and will require some intervention. Similarly, a cuff which gets rolled down and cause obstruction in Soaves will also cause a significant obstruction requiring some intervention. But as such, in a long-term follow-up, it is not that you will do a procedure and the patient will become totally fine. He will have some issues. Some patients will have some constipation. Some patients may have oiling for some duration. And these are inherently associated with that particular procedure. So probably what they are saying is that they have noted constipation more frequently as such in a large group. These patients may not require intervention, so intervention was required only in 8%. While these complications or constipations were not that frequently seen in Duhamel and all. So that is practically possible, but you should know what specific thing leads to a significant complication requiring some surgical intervention.
They wish to know the 8% what was the rate. Okay. The people needing some intervention to be constipation. What was the commonest operation done? What do you think you will do in Swenson's?
I don't think yes, Tyson का है it in general.
In general का है।
इसका distribution बता दिया।
Okay.
So
मैं elaborate करता हूँ।
Action will probably help in Duhamel if a retained spur is there, and if cuff has caused obstruction, then it's obvious.
Yes.
But that is what means the constipation needing critical intervention will be more common in Soways and Duhamel, but overall constipation will maybe more common in stress.
Yes.
That is the
Yes, sir. It's a mixed group. Yes, sir. This was a paper by Langer et al. From Ontario. He divided their patients of constipation into mechanical obstruction, those that were because of recurrent or acquired ganglionosis, motility disorder, and internal sphincter or functional constipation. This is the paper that gave this algorithm that is present in most of our textbooks for the workup of patients with constipation. One can look at that article. It's a very nicely written article. Enterocolitis usually is a fairly frequent constipation, and rates after pull-through vary widely among these series. This variance is more likely related to because there are differences in the definition of enterocolitis in different studies, and a differentiation from other processes like gastroenteritis or a spasm of the internal sphincter is also possible. But current rates in across different studies are as low as 2% to as high as 43%. Now, when we look at the largest multi-center retrospective review from Teitelbaum et al., who looked at enterocolitis specifically also in their group, this study was done from May 1989 to 1999 and had 78 units. All these units underwent endorectal pull-through at 4 different pediatric surgical institutions. This study had the highest rate of enterocolitis, and this is an older study. And here, significantly greater incidence of enterocolitis was seen in groups of primary endorectal pull-through, and which was and they've seen risk factors that were responsible. Anastomotic stricture and perioperative nutrition were the most important significant risk factors. Enterocolitis also is reported to cause number of deaths in several series of Hirschsprung in the postoperative period. In fact, any death that is in a child of Hirschsprung that is directly related to Hirschsprung disease, approximately 50% of those deaths were related to enterocolitis or complications that were related to the enterocolitic episode. Majority of these deaths occurred within the first year following pull-through. And if we see, Swenson described that most of his patients of enterocolitis have been treated conservatively only, and most of them occurred within the 2 years of life, 2 years after pull-through. And the association between enterocolitis before pull-through and the incidence after pull-through is also described. Like children with enterocolitis before the procedure usually tend to have enterocolitis after the procedure also. But this trend is currently in the recent studies not seen by many authors. And it is described that conservative management should be mostly enough for cases after pull-through. Internal sphincterotomy in patients with persistent enterocolitis is also described, but that is only very scanty number of studies. Coming to primary pull-through, usually children with primary pull-through have a higher incidence of enterocolitis, and depending on the series, I've found that rates are comparable or even higher than those who underwent a staged procedure. A transanal approach usually is the most popular approach. And the latest papers are again varied here with incidence of 6% and 35% of enterocolitis here. Coming to stricture formation, this usually is again varied from around no stricture to 20%. Like 0 to 20% is the difference. And most of them responding to dilatations are what unanimously all the papers conclude. Only 1/3 of them usually require any surgery. And the type of pull-through versus stricture formation, there is no association. And highest incidence of stricture was usually seen in the child that develops early postoperative leak, because logically we see that an early asymptomatic non-subclinical leak causes a stricture. In Swenson's 25-year follow-up study, he saw only that 3 patients of his 23 developed stricture. 3 out of 23 had stricture after the leak in the early postoperative period. Now, that paper by Teitelbaum et al., here again, he showed that there was no correlation between stricture formation and the tension of the anastomosis, the poor blood supply, or the level of aganglionosis. This was a paper that showed, initially people thought that tension or poor blood supply or a younger group of children can cause stricture formation, but his study did not reveal those results. Their values were not statistically significant. Probably poor is the clinical judgment of the surgeon during the procedure, sir. Wo, again.
This doesn't look, you will have to read it more
In detail.
Otherwise, has written excellent papers.
Yes.
He is a good name
Yes.
in this field. But I don't know how he derived this.
This was the conclusion. Yes.
But this is what we have seen clinically also. The patients who had a poor blood supply in this schema is there. The digestion does occur. So that is true for esophageal atresia and it will be valid for this also. This is basic surgical principle. So you will have to see what exactly has led to come to this conclusion.
Plus, they are putting P values and all on the finding which is absolutely subjective. I don't know what is that are also all the major and derive a P value out of it. How you do poor blood supply. Okay, nowadays, if you have ICD, this thing, fluorescence studies, you can compare poor fluorescence more, but that time I don't know how you can actually say poor blood supply and get a P value out of it. Only that no correlation. Subjectively, sometimes we respond. There is a correlation between structure and tension. No correlation.
No correlation.
So this matter of how they understand it, but for doing this, you have to give an hypothesis. There is a correlation between this.
हमेशा ये होता है कि कोई
Correlation.
फिर उसके बाद में अगर ये significant आ जाता तब हम उसको ये कहते हैं कि yes, this is not the reference जो आया है, that is not by chance.
Yes.
जब हम बेसिकली स्टार्ट करते हैं ना तो हम ऐसे ही करते हैं कि जो भी हम दो ग्रुप कर रहे हैं उनमें कोई डिफरेंस नहीं. दिस इज हाउ वी स्टार्ट विद द लाइफ. क्योंकि दूसरी अल्टरनेटिव हाइपोथेसिस को स्टैटिस्टिकली प्रूव करना ज्यादा चैलेंजिंग होता है, ज्यादा मैथमेटिकल वो चाहिए होते हैं, डिफिकल्ट होता है. तो स्टार्ट तो यहीं से करते हैं. तो इसलिए ये तो यही मतलब बता रहा है, पर कैसे किया वो वाला वैलिड पॉइंट है कि ये इसको पढ़ना पड़ेगा कि एक्चुअली ये कैसे.
Yes. And again, when it comes to impotence and the voiding and sexual problems, here in the larger group of studies, basically this incidence is actually very low. The Swenson's procedure intuitively appears to have the highest risk of injury, but the results say otherwise. In this whole follow-up period of 25 years, again, in the same paper, no patient that was followed up to puberty actually had impotence. And finally, almost 80% of his, 80 children of his were evaluated. They were happily married and had cumulative children of 146 also. So he said that urinary incontinence and impotence in his paper are actually 0. Urinary dysfunction, this again is actually very rare. And several series have been consistently showing that on long-term follow-up, the incidence of urinary dysfunction is actually very low. And incidence of Swenson's pull-through, again, the incidence is low in this case also. And many studies have replicated the results. Like it is as low as 0% in Swenson's own study. Late mortality, the exact cause of death is often not mentioned usually in studies, and variety, there's varied description across literature. In some studies, HAC was responsible for 50% of deaths, but in others, again, no deaths were reported in HAC. So again, literature is diverse. Other causes of death usually include bowel obstruction, pneumonia, and other non-related medical disorders. And no specific pull-through is related with higher rate of late deaths. Overall, when we see quality of life, coming to the ending of my slides, 87% of children were graded as having a good to fair quality of life, and most of them were found to have psychosocial disorders that were different from control group of adolescents. But however, there is significantly, their quality of life is lower when compared to healthy adults. To summarize, so one should keep in mind these three group of patients: incontinence, constipation, and enterocolitis, and one should adapt a systematic approach in dealing with them, starting from history, taking a good surgical history, looking at bowel habits, what are the obstructive symptoms, and what are the prior treatments the patient has been on. And a contrast study is usually helpful, and one should to delineate the postoperative anatomy and look for colonic motility. Then an examination under anesthesia is a must when cases are not resolving with clinical conservative management, and a full thickness rectal biopsy in the algorithm. And in case of incontinence, this is a helpful algorithm wherein one could look at sensation and sphincter function first, and if they are intact, then do a contrast enema, rule out correctable causes, treat the correctable causes by conservative measures. If soiling persists, then look for colonic motility. If hypermotility is there, then again try conservative management, use anti-motility agents. But if still persistent or very severe incontinence, which is debilitating, then probably a child should be kept on a enema program for life or even a proximal ostomy. Constipation, again to summarize, mechanical obstruction, if it is present, then dilation versus revisional surgery like we've described in the previous slides. If there's no mechanical obstruction, then pathological cause ruled out by rectal biopsy. And if pathological cause is there, a redo pull-through is required. But not there, then we move on to functional causes, botulinum toxin injection the first go. If clinical improvement is there, then we repeat and follow up that patient. If it is not there, then we work up for motility disorders, and then depending on that, do the management. Enterocolitis, to summarize, grade 1 patients, oral antibiotics, OPD basis usually enough. Grade 2 patients, inpatient admission usually is done in most cases, requires metronidazole and possibly additional broad spectrum coverage. And grade 3 patients, IV antibiotics, both metronidazole and the broad spectrum. And here probably even diversion will be required. So to conclude, this is a neurogenic intestinal obstruction, like we all know, with a potential for a chronic illness, and a wide spectrum of complications are reported. And our continued understanding towards the bowel motility disturbances improves prognosis. And fortunately, majority of the patients do well, regardless the technique employed. And more than 94% of children are well-adjusted members to the society. And one should always remember that our role as a surgeon is to set realistic expectations with the parents from the beginning itself and keep the patients under close surveillance. Thank you.
So it was nice presentation.